Yes. Timer is on, and here is your question, please.
Okay, ma'am.
Right. So if you've read and understood, kindly tell me, considering it critical care station,
Yes, ma'am.
how would you manage this patient?
Considering this scenario, I would actually like request protocol.
Yes.
So I will go with the ABCD approach. Specifically, I mean, I would confirm that the airway is patent and the breathing is equal. I would be mainly concerned with the circulation in this case.
Yes.
As such, I'll be observing the pulse rate, blood pressure, any capillary refilling deficit, urine output as well, and then I'll check for any if there's any disease or disability as such, and I would examine from head to foot approach.
Yes.
I would also look at his background. Examination of his chart, which shows that he's having previous renal impairment already.
Yes.
And currently his renal function test has deteriorated significantly. So I'll be concerned about that. And also his recent labs, which shows potassium is significantly elevated.
Yes.
So I would definitely start a cardiac monitoring for him.
Yes.
I would continue cardiac monitoring. I would stop any potassium-containing medications or any potassium-sparing diuretics, which can cause elevation of his serum potassium levels.
Yes.
I would initially like to stabilize his heart, so I will give him calcium gluconate. I will give him 10 mils percent calcium gluconate over 10 minutes.
Very good.
And I will also like to start him on salbutamol nebulizations, 5 to 10 milligrams for 10 minutes, for half an hour, 10 minutes
Yes.
apart.
Yes.
Following that, I would like more stabilization. So I'd like to give him on insulin glucose infusion to 10 with 50 mils or 50% dextrose over 30 minutes. And in patients who are having potassium levels more than 6.5, here it is 8, so I could even consider hemodialysis for more sustained hyperkalemia.
Yes.
And I would give him calcium resonin calcium resonin for more sustained control, 30 milligram per orally.
To make
And
your
I can also consider.
yes. Yes.
Sorry, ma'am. Yeah.
To
So in order to correct the acidosis, I would consider giving him sodium bicarbonate as well.
Very good. So if you have to confirm your diagnosis of acute kidney injury, what would you do? Or how would you confirm it that it is acute kidney injury? What investigations would you do? Or yes.
I would check the urea and electrolytes and check for any sudden deterioration of worsening of renal function test, which is there in this case.
Yes. Input output charting. Urine input output
chart.
Yes.
Yeah.
And all right. Okay. One more question. Can you tell me if you'll do the hemoglobin of this patient will turn out to be anemic? Why? Patient with renal impairment.
It could be because of chronic renal impairment, so there could be deficiency of erythropoietin.
Yes.
And also in this patient, there could be long-standing history of obstruction. So there could be bone marrow depression secondary to increasing age or fibrosis or such, and these can be causes this chronic anemia secondary to age or any other diseases.
So
I would mainly
what type
consider
of
deficiency
anemia
of
would you see?
It would be a normocytic chromic anemia.
Yes, very good.
That I would suspect. Yeah.
Yes. So tell me, you said you will consider hemodialysis. What are the indications for going for hemodialysis?
The one indication that I know is potassium level more than 6.5 in this case.
Yes.
And also, I said hemodialysis because the patient is already known to have chronic
Yes.
renal impairment, which could aggravate his condition as well. So he would be a good candidate. I'm not sure of the other indications.
There could be fluid overload. There could be urea greater than 30. There could be even chronic renal failure with creatinine clearance less than 10 ml per minute. Could be encephalopathy and acidosis with pH less than 7.2. Okay, what are the ethical considerations that you will consider before putting the patient on hemodialysis?
In this patient, he's having dementia, and
Yes.
I would consider that he was actually not capable of taking decision by himself. So I would have to take the decision in the patient's best interest.
Yes.
And I would have to consider taking a form 4 in this patient with the agreement between two consulting physicians who's in the
Very
care of
good.
the patient to go ahead
Yes.
with hemodialysis.
Yes.
I would also have to involve his carers and his GP and whoever is involved in his care for long term in order to set a plan which is followed up by triage. So I would have to involve I would have to go for a multidisciplinary approach.
Very good. Can you name a few causes of acute renal failure?
Could be pre-renal, renal
Yes.
causes or acute or post-renal obstructive causes as well. In this
Yes.
case, it's post-renal causing multiple recurrent episodes of UTI and obstructive uropathy. Could be renal causes as well, diabetic nephropathy, renal tubular acidosis, acute kidney injury or chronic kidney impairment.
So what are the,
Not able to get
you've
the
already, what are the complications of acute kidney injury? This can lead to
the high, elevated urine creatinine multi-organ failure secondary to
yes.
kidney injury.
Yes. Okay. Could be because of high potassium, acute pulmonary edema, and all those. All right, you told me. You told me how you will manage the potassium since it is high, but how would, in a scenario, how would you manage the potassium if it is low? So
I
how would
would
that
give
patient?
potassium supplementations.
Yes.
If
How
the
would
potassium
patient
level is less than
present?
3.5,
Yes.
I would.
Yes.
In patients with hypokalemia, the patients were the presentation can vary from mainly muscle-related problem, muscle weakness and cramps. There could also
Okay.
be cardiac abnormalities. So the in ECG will show variations such as
U
flattening of
waves.
T
Yes.
wave along with
Emergent.
ST segment depression,
Yes.
prominent U waves, and severe hypokalemia can also result in torsade de frontis and ventricular tachycardia.
Okay. All right.
And also prolonged hypokalemia can result in cardiac, cardiac arrest and diastole.
Okay. Right. Can you tell me why? Okay. What is the function of potassium in the body? Why do we need it?
So potassium is mainly an intracellular anion, so it's mainly used for maintaining the electric potential between cells. It can also improve. I mean, it's also useful in conducting nerve impulses, muscle function, cardiac function, and for maintaining proper fluid and water balance in the body.
Yes. Okay. Why patients with acute renal injury present with uremia?
My patient. I'm sorry. I'll come back to the question.
Okay, that was the last question. All right. What is
Patients
the
presenting with
function?
acute kidney injury present with
Yes.
uremia? Obviously, I mean, or
You knew
decreased
it.
clearance of
Yes.
urea, or I guess. I mean, I don't know. That's why.
Can you tell me the functions of aldosterone?
Functions of aldosterone. It causes sodium reabsorption in the DCT and cortical collecting duct instead, and there will be in exchange potassium is excreted.
Good. Yes. Thank you so much. Excellent. This was your first time you presented any session, and it was very good. I'm
Prepare for the
happy. Yes.
station. Thank you.
This is the first time you have. Yes, so you will not start with CRISP
Listen to
protocol.
investigate.
So Dr. Abhishek, would you once please clear it when they have to go for CRISP protocol and when they have to go for ABCD?
Actually, everyone knows it. Like the
Yes,
first
but
thing,
still,
like
we in
if
the
it is a
exam
trauma
scenario,
case, yeah,
yes, stress, we
yeah.
forget. So we have to
And
repeat it again and again, yes. And this
so
was
in
his
any
first
kind of
time.
post-operative patient, like what is CRISP? Care of critically ill surgical
Yes.
patient. Like patient had his surgery or patient is going to have a surgery, something like that. In that case, we'll apply the CRISP protocol, and according to that, we'll apply the ABCDE, then do the three things like chart review, checking the history. Okay, that includes the checking the history and taking adequate relevant clinical examination and sending the new sets of investigation. And after that, we'll decide a plan that completes the CRISP protocol. So, and
Good.
the ATLS protocol, that is advanced trauma protocol, right?
That
So
is for
if there is
trauma.
any case of trauma, yeah, if there is any case of trauma, we will start with ATLS. Then from the ATLS, we will start ABCD. And
What about for the
in
burn
ATLS,
patient?
it will include also with the for burn patient, ma'am, it's a trauma case, ma'am. I'd go for ATLS.
Yes.
And in
You have to check
ATLS,
the
we
MRA
have to do
first.
the cervical spine immobilization,
Yes.
but in CRISP, we don't have to do
We
that.
don't have to. Yes.
If there is any obvious pathology in the cervical spine or,
Yes.
yeah, that's it. And if it is confusing, like it is an emergency patient, but there is no history of trauma, not a surgical patient, we'll start simply with ABCD protocol. That's it.
Yes.
And can you answer? Can you
Clear,
answer
Dr.
that
Sridhar?
indication for? Yes. Thank you, Dr. Abhishek. The answer
Yeah,
for indication for hemodialysis. What was? I mean, fluid overload,
that
encephalopathy,
is the 6
acidosis, and
points,
what else?
brother.
Six.
Yeah,
Yes.
that is 6 points. First of all, fluid overload. Okay. Second, hyperkalemia. We know hyperkalemia is always associated with metabolic acidosis. So hyperkalemia, if
Greater than 6.
potassium more
Yeah.
than 6 millimole per liter, then metabolic acidosis. So less than 7.2. If it is less than 7.2, then we'll focus on the urea level. If it is more than 30, okay.
Yes.
Then two more things, that is chronic renal failure and the creatinine clearance rate less than 10 ml per minute. That is one point. And the last point is uremic encephalopathy.
Yes.
Okay.
Okay. Yeah.
And
That is the
causes of
indication
acute,
for renal
yes,
replacement therapy. Okay. Yeah.
acute renal failure, it's diabetes mellitus, ATN, PN, it's too many. And then these
Yes, ma'am.
potassium,
That is the
hemostasis of
renal
potassium.
cause. Yes.
Yes. Then you have to know endocrine and renal causes why you need potassium.
Yes, ma'am. For
So this
hemostasis.
you have
Yes.
to go back and read, because why potassium is
Yeah.
important. So you have to go back and read the functions of potassium for endocrine or for renal reasons, why it's important. Then you should like learn them on tip of your
Okay.
finger. So these are like 2 3. And then
Yeah.
endocrine, you also in endocrine aldosterone, I asked you function directly because you couldn't tell me in another way.
Yeah.
So,
Yeah.
It
Yeah.
decreases the potassium, right?
yes.
Yeah.
Stimulates
Mm.
sodium
For
and
endocrine,
causes the,
yeah, insulin
yes,
and aldosterone, right, ma'am?
yes,
Yeah.
yes, yes,
Stimulates sodium reabsorption instead of potassium.
yes,
So potassium
yes,
will go out and
Instead of
sodium gets
potassium,
absorbed
yes,
back
in
in.
exchange of
yes. It
potassium.
In
promotes
DCT and
excretion. Yes,
CCT.
yes. So that
Yeah.
these are the
DCT and
functions, like
CT.
you have to be specific and tell. And in renal also you have to tell how it acts in acid base balance and how
Tubular flow
what
rate
role.
and
Yes,
acid base
yes,
balance. Yeah.
yes, those. So once, because when you asked me to present and then it got 1 or 2 days, maybe you forgot, that's why. But then we'll repeat again and again, so these things will become on your fingertips and will not forget them. Besides, this is good
And
good
your
topic
management
for.
protocol was really great, Dr.
It was
Sridhar.
very
Yes,
good.
Thank
Yes,
that was really great.
yes.
Yeah.
Without wasting any time, he went straight to the cause, and it was good management. Very good impression it gave right
Yes,
away.
ma'am.
Yes, very good. Anyone interested in any random station? If not, then we'll have it for tomorrow.